My name is Ammar Lakda, and I'm a Foundation Year 1 intern doctor at the Queen Elizabeth Hospital in Birmingham. Today, in collaboration with Professor Rafi Avitzian, fellow of the American Society of Anesthesiology, I'll be presenting a case of emergency airway management for a patient with a T-tube tracheostomy. The goals of today's presentation are to gain familiarity with the Montgomery T-tube airway device, to understand its unique considerations during airway management, and know how to use or exchange the T-tube for emergency airway management. So, the case in question is one of a 53-year-old female on the surgical ICU with an extensive past medical history. This is most notable for subglottic stenosis, for which a Montgomery T-tube was placed in situ. This is also along with some other medical comorbidities such as aortic or AF, prior ischemic stroke, type 2 diabetes on insulin, hypertension, hyperlipidemia, obesity, and prior breast cancer, as well as a significant past pack smoking year history. The patient presented with new onset stroke requiring an embolectomy. However, managing this airway ahead of the embolectomy was not straightforward. Initially, it was attempted to pass a 4.0 MLT through the extratracheal limb of the T-tube. However, this was done because of the patient's history of full occlusion to proximal flow. This, however, resulted in poor tidal volumes, increased end-tidal CO2, increased inflation pressures, and hypoxemia. And ultimately, it wasn't possible to ventilate through the T-tube. The T-tube was then replaced as ENT were called, and it was replaced to a 6.0 cuffed shyly through the stoma. Initially, it was placed at 15 centimeters, which resulted in right main stemming, so was withdrawn to 10 centimeters. This resulted in increased tidal volumes, improved end-tidal CO2, and oxygenation of up to 100%, therefore securing the airway and readying the patient for the procedure. However, the case highlighted the challenges that can arise with an unfamiliar device in the neck and how these challenges can be exacerbated in an emergency. So, let's take a step back and examine what the T-tube actually is. This is an uncuffed silicone T-shaped device that serves both as an airway stent and as a tracheostomy tube. It consists of two limbs, the extratracheal limb that protrudes out of the neck stoma, as indicated by label B, and the intratracheal limbs that extend up into the trachea and out through and toward the oropharynx, and then down toward the lower airway, indicated by labels A and label C. Again, it can be used as a bridge to definitive reconstructive surgery or structural tracheal pathology, or even as definitive treatment when surgical repair isn't possible. It's a semi-rigid and deformable tube that is compatible with a wide variety of speaking valves. It's available in different sizes, and the limbs can be trimmed to different lengths to customly fit patient anatomy. However, the device is very difficult to identify in situ, so it's important to look for its soft silicon material. The T-tube itself comes with a number of anesthetic and airway management challenges. It's not provided with standard connectors to fit bag valve devices or anesthesia breathing circuits, and therefore you must modify it to attach it to 15 or 20 millimeter standard connectors to attach to an anesthetic circuit. The upper open end can cause a loss of inspired gases and therefore ineffective positive ventilation if you're trying to ventilate through the stoma site. This can result in hypoventilation, inadequate depth of anesthesia, and a risk of awareness. The smaller internal diameter of this device compared to other tracheostomy devices can also prove difficult during airway management. And given its indications, the presence of this device in situ can be an indicator of a difficult oral intubation because of the tracheal stenosis, as well as the narrow tubing of the device itself. It has a difficult shape to remove, and it's very susceptible for granulation tissue to form in and around the lumens of the tube. And because there's no inner cannula that can be removed, mucus plugging of the device is very difficult to resolve. So, when we think about managing the T-tube airway, we can either ventilate through the T-tube itself, or we can insert a new airway tube. If ventilating through the T-tube, we can either use the extraluminal limb protruding out of the neck stoma, or the intraluminal limb through the oropharynx. If using the extraluminal limb, it can be more difficult to predict the circuit adapter size, and a poor fit can actually damage the T-tube itself. This lack of being able to predict is more likely in an emergency situation. If using the intraluminal limb, the limiting factor is often the degree of upper airway stenosis, which isn't always known in an emergency. It may be possible to use an LMA and bag mask ventilate through the oropharynx, but again, the limiting factor is the upper tracheal stenosis. If using either limb, there is a risk of airway leak, as mentioned before, from the other limb that isn't being used. It has been shown to include the limb in the literature to effectively ventilate using tools such as a Fogarty catheter, a Foley catheter, or a piece of gauze. However, these have not always been effective. If inserting a new airway, this can be done through the extraluminal limb, the intraluminal limb, or removing the T-tube device itself and replacing it with an ET tube, just as we did in our case. If using the extraluminal limb, the major considerations are the 90-degree angle from the soma site to the lower airway and the smallest lumen diameter. Again, if using the intraluminal limb, again, the limiting factor does tend to be the degree of upper airway stenosis. Although this limb is larger than the extraluminal limb, it's still very narrow, and it can be difficult to pass a tube through this. Also, if passing a tube from above, there is a risk of displacing the T-tube down into the lower airways. To take out the T-tube completely is usually the first line emergency management for other tracheostomy devices as well. And again, this is something that worked in our case. However, it's not without its dangers. Because the T-tube is often used as a stent to hold the airway in place, to hold the airway open, removing it can pose a risk of airway collapse. Again, it can also be very difficult to remove because of the granulation tissue performance. So, a number of different cases of T-tube management have been reported in the literature. These are mostly elective situations. However, there are no universal guidelines from all of these cases. There are 2 existing cases of emergency management aside from our own reported as well in the literature. The first, by Toma and colleagues, is one of a patient in cardiorespiratory arrest. The team tried to occlude the extratracheal limb and mask from above. However, this resulted in insufficient flow through the tracheal stenosis. They then tried to connect a bag valve device to the extratracheal limb, but this resulted in too much gas escape into the cephalic intraluminal limb and into the oropharynx above. Therefore, they opted to involve ENT and remove the T-tube, replacing it with an endotracheal tube. The second case, reported by Robinson and colleagues, was one of a patient extracted from a road traffic accident requiring airway protection. An awake approach was used with lidocaine to topicalize the airway, and a pediatric bougie was passed through to assess the diameter of the tube of the intraluminal limb. However, this faced obstruction. They therefore directly opted to involve ENT to straightaway remove the T-tube and replace it with an endotracheal tube. This therefore shows that both of the emergency case management reported in the literature, as well as our own, have all opted to remove the T-tube. So, ultimately, from our experience and of others reported, we feel like the key to managing a T-tube airway in the emergent setting appears to be involving ENT and attempting to replace the device with a cuffed ET tube, to later replace with a T-tube in the elective setting if possible. If managing entirely in the elective setting, similar principles apply, but given the fact that there's often more time to prepare equipment and personnel, this is often a lot safer. In an ideal case, one could replace the T-tube electively before the main procedure, requiring airway protection. So to conclude, the Montgomery T-tube has its unique complexity, giving rise to unique challenges in airway management. At first glance, it resembles a traditional tracheostomy tube. However, its presence may significantly complicate airway management due to factors of both the device and the patients that it's found in. Again, these complicated factors can often be exacerbated in emergency settings, and therefore it's essential to have a comprehensive preoperative assessment and adequate preparation when making anesthetic plans for these patients. Ideally ahead of emergency situations, if a patient with a T-tube presents. When managing the T-tube, it's really important to take a multidisciplinary approach with the essential involvement of an otolaryngologist who's familiar with the use and insertion of T-tube devices where possible. Thank you very much for your time.